Welcome to today's National Neonatal POCUS Collaborative webinar. I'm Carolyn Vexstein, and I'll be your moderator today. Before we start, just some general housekeeping items to make note of. The chat is disabled for the audience, but the moderators may send out general announcements via the chat. Please use the Q&A feature to post questions. There will be a Q&A panel session after our featured presentation. This webinar is being recorded and will be uploaded to the collaborative website, neopocuscollab.com. Now on to our main talk. It is my pleasure to introduce Dr. Monti Sharma and Dr. Jason Stoller. Dr. Monti Sharma is an attending neonatologist and pediatric pulmonologist at Children's Nebraska in Omaha. He is also the director for neonatal POCUS at Children's Nebraska. He has a strong interest in developing standards for procedural and diagnostic ultrasound application in the neonatal ICU. Dr. Jason Stoller is an attending neonatologist at Children's Hospital in Philadelphia. He is dedicated to advancing point-of-care ultrasound in neonatal intensive care. Through collaboration with multidisciplinary teams, he aims to improve procedural safety, diagnostic accuracy, and workflow efficiency, setting new standards for neonatal care. Dr. Sharma and Stoller, please take it away.
Great. Thank you so much for the introduction. Let me just put up my slides here. All right. Continue to share. All right. Great. Thank you so much again. So today we're going to talk about using point-of-care ultrasound to evaluate the spine and doing lumbar punctures. And I'm going to give you some of the background and go over some of the technique and what mostly what we do here at Children's Hospital of Philadelphia. And then we're going to kind of tag team, and Monty's going to give you some tips and tricks that he's learned at Children's Nebraska. So why should we even think about using ultrasound for lumbar puncture? So LPs are frequent in the NICU. 10 to 20% of patients admitted will need an LP. But unfortunately, the failure rate is quite high. And this not only reflects the literature, but our own local data as well. But, we fail about a third to a half of the time. And that's just getting fluid. Once you get fluid, of course, many times it could be traumatic, depending on whether it's the first try, second try, depending on what else is going on with the baby. But incidence rates of a traumatic LP, are around to a quarter to 50% of even those times where we are able to get fluid. So when we think about using point-of-care ultrasound for doing lumbar punctures, there's basically two approaches. There's the static approach and the dynamic approach. In the static approach, what you're doing is you're looking at the baby's spine, you're looking for adequate CSF, you're looking for any unexpected anomalies, and then you mark the skin at the optimal location. Then you put your ultrasound machine aside and you just do a traditional LP. That's in contrast to a dynamic ultrasound guided LP, where we take all of those same steps where we look at the spine, we mark the right spot, but then we're actually using the ultrasound probe and putting it over the area where our needle is, and we're watching the needle enter the CSF space in real time. Okay, so there's a static approach and the dynamic approach. And we're going to show you some images of both. And I would really encourage people just beginning to use point-of-care ultrasound for LPs to really just focus on the static approach until you're very comfortable with that. And then later on, start to use the dynamic approach. So what probes should you be using? Mostly what we recommend is to use a linear probe. The size is not that important. You can use kind of microlinear probes that are shown on the left and in the middle, or you can use a larger linear probe shown on the right. And in some of the images that we'll show the next couple of slides, you'll see around where the depth should be set, but it's around 2.5 to 3 centimeters. All right, so the first step is to just put the probe on the baby's skin. In this image, the baby's head is to our left side, and we're getting a longitudinal view of the baby's spine. And what we see here, we see this beautiful image. I'm assuming you all are in neonatology, so you picked the best specialty, of course. And our babies are basically translucent when it comes to ultrasound. So we can see right into the spinal canal. On the left side of the screen, you can see the conus medullaris and the central canal, or those two horizontal paired lines in the middle of the conus medullaris. And I remember one of the first times that I looked at a baby's spine, I was surprised that the conus medullaris looks anechoic or black. But the reason that is because there's a ton of fat that's around the sheath of the nerves and the spinal cord and part of the spinal cord, and fat appears relatively anechoic. Then on the right side of the screen, you can see the little white wisps. Those are the spinal nerves. And in real time, it's really amazing. You can see the spinal nerves just kind of like floating around in real time. And we'll see that in some of the images. And then the anechoic black area on the right side of the screen where the arrow is pointing to is all CSF. Then at the bottom of the screen in white, these are parts of the vertebrae. And this is the ideal midline view and looking at a longitudinal orientation. Now, if we turn our probe 90 degrees and we see how our view changes, what we see now is a cross-section through the spinal canal. So our anechoic black spinal cord now just looks like a circle in the middle of our screen. And then our cross section of the nerves just appears all these tiny little dots squished together, surrounded by a black anechoic CSF. Now, this would be too high. You would never want to stick your needle here because there would be a risk of hitting the conus medullaris. So, in this same orientation, if we slide our probe down towards the baby's feet very slowly, what you'll see is that anechoic circle in the middle disappears, and we're just left with the cauda equina, the nerves kind of floating around in the CSF. So this would be a perfect level to do your LP. Now, when I do my marking procedures, what I'll do in this orientation is right at this perfect level, I'll make a mark on the baby's skin. And I use these sterile surgical markers. And you can do it while you're sterile or before you're sterile, but I use these markers because I know they won't make an indelible mark on the baby's skin. I have this unfounded fear of giving the baby the worst tattoo ever. So we make our first mark, and that's our kind of do not go above line. And then we slide the probe further down towards the feet. And what we're looking for here is we're looking for the spinal canal as it narrows. So the same image that we had on the left, that's our perfect spot. But as you get lower and lower towards the baby's feet, you can see the spinal canal gets narrower and narrower. And you just have to decide by sliding up and down where is too narrow for you. And so once I get to that spot where I decide it's too narrow, I put my second mark, and that's my do not go below. So these are my kind of, for a football analogy, these are my goalposts. Then this is kind of an optional step. I turn my probe back 90 degrees again, and I find the exact midline position, and I make two marks, superior and inferior. And then also you can measure the depth shown on the right side of the screen, and that's the depth from the skin at the top down to the posterior dura, which is that thick white line. It ends up then in the NICU, this depth is fairly consistent, even between tiny preemies up to full term, it's, always less than 1.5 centimeters to get to the center of the CSF space. But you can measure just to reassure yourself and have that knowledge. And then I wipe off all the gel and I take my surgical marker again and I make my markers darker. Um, this is just one way of making the marks prior to doing my static LP. There are other strategies that you might read about, and other people in my division find the optimal interspinous space and mark it with an X, and then they know exactly where to put it. So there's different styles of doing this. Now, if you take a transverse view and you turn on your color Doppler, you'll see this extremely frightening view where you can see the spinal canal is surrounded by arteries and veins and venous plexus and a venous plexus. But you can see that while these vessels can be anywhere, they're predominantly on the left or right side of the spinal canal. And when we get to doing a dynamic LP, I'll point out why this is particularly important. All right, another point that I want to make is more and more I've tried to do this in the sitting position. And the reason why is here's a baby who's in the left lateral DQ position, which I'm guessing is the position many of you do an LP in. And at the bottom of the screen, we can see a longitudinal view of the lumbar spine. And you can see there is a decent amount of CSF space there. But if I simply sit up my patient like this, so I just put a little towel on their lap, I have their arms draped over the towel, and the nurse is just holding the shoulders and the head, and then I repeat my LP, you can see that the CSF space gets dramatically bigger, right? So all that CSF is helped by gravity to push down towards the lumbar spine, and the CSF space in the lumbar spine expands. So I've done this more and more, even in intubated patients. It takes, an intubated patient, it takes a lot of help because I ask a third person just to sit there and watch the ET tube, but it can be done. This, I have no stock in this company, but this is a device that we have here. It's commercially available, but it's a device to safely secure late preterm and full-term babies in kind of the perfect upright sitting position. And there's a hole in the blue part there where the baby's face is visible and they can breathe. So that's an option too, but the rolled up towels on the lap works as well. Now this is really critical, a really critical point for those who are just starting with ultrasound or just starting to think about using this for LPs, particularly dynamic LPs. So if a baby's sitting up and their skin surface is shown in brown there, and the dura is shown in green, and we put our probe perpendicular to the skin, the sound waves come out, they bounce off at a 90-degree angle, and we see a perfect image of the baby's lumbar spine, spinal cord, etc. But unfortunately, this is not how we do an LP. If we were to try to insert the needle in this position, none of the sound waves would bounce off the needle, and therefore we wouldn't see the needle at all. So what you have to do is you have to put the transducer on the skin at an angle, and you have to insert the needle at an angle slightly up towards the baby's head. This actually works out fine because the spinous process doesn't come out directly posteriorly. It actually comes out posterior and a little bit inferiorly. So the needle, as shown here, actually is almost parallel with the spinous process. And when you do this, sound waves can bounce off it closer to a 90-degree angle, and you actually will be able to visualize the needle on the screen. So this, always remember your angle of inclination when attempting this. All right, so here, now we've shifted to our dynamic approach. And what we're looking at here is transverse orientation, where the needle is right under the probe, and we're slowly advancing the needle. And when you can see very briefly in the middle, right there, I don't know if you can see the pointer, but right here, let me play it again. Right there, you can see the needle point, okay? So I put the needle in a couple of millimeters and I advance it. And the goal of this view is just to ensure that I'm absolutely midline. I don't want to be over to the left or the right because remember those horrifying blood vessels that are to the left and the right, I don't want to be anywhere near them or else I'm certain to get a bloody tap. All right, so then when I know I'm exactly midline, I shift into my longitudinal view, and on the left side of the screen there, you can see um, the needle coming in at an angle and entering the CSF space right there. Okay. Another thing you'll notice in this view, it's not well shown in this video, but the dura is very, very tough. Sometimes you'll see it tenting and tenting and tenting, and then it'll just burst through. And that, in even a normal LP, that's the pop that you feel sometimes. All right, here's another view of a dynamic LP. Oh, there you can see the pop. Let me play that again. All right, here we're advancing, advancing, and then pop right there. We popped in. Now I would remove the stylet and look for CSF. All right, so here's some examples of just some interesting findings when we've done LPs. Here, that bright white line in the middle of the screen is the dura, and you can see a small amount of CSF just below it. But what you notice right above it, particularly on the right side of the screen, is a large volume of hematoma. So this, would be a very tricky LP to do to try to get through that hematoma and into the CSF and get a clean tap. Not impossible, but quite difficult. And here they are trying it. You can see there they pop through. The needle's on the right side of the screen. All right. Here's another one where we've put the probe on the skin, longitudinal orientation. The white posterior dura is right here. And then right above it, you can see what looks to be CSF, but actually that's in the wrong anatomic location for CSF. So that's epidural fluid. On this, it seems hyperechoic, so it might be blood. It could be just epidural fluid of some other sort, maybe from a CSF leak or something like that. But definitely don't confuse this with the normal CSF that you're shooting for. The CSF that you want is right below it. And there it is in video. Here's the same clip in a transverse orientation. You can see right here above the bright dural line is epidural fluid. All right, so here is another image. This time there's a hematoma anteriorly, so below the anterior dura here. And you can see that it's making the CSF space kind of taper, probably prematurely. Okay, here's another view of an epidural in, right here, this anechoic fluid that is posterior to the dura. Same patient in a transverse view. Anteriorly, you see fluid. That's not CSF, that's epidural fluid. It could be CSF, it's just not in the right spot. All right, another very, very common finding, and this time we've reversed our probe. So the baby's head is now to the right side of the screen. And if I play the video, right here in the middle, you'll see a small filar cyst, which are very, very common, especially right after birth. You probably see this in 10 to 20% of patients, and eventually that number goes down as the child gets older. And I'll show you a bigger one. So this is a large filar cyst. You can see the baby's head is to the left. This is the conus medullaris, and then you can see a big filar cyst there. This doesn't prevent us from doing a lumbar puncture. I don't actually know what the fluid is inside there, but I'm guessing it's not the CSF that we want to sample. So I might move down towards the baby's feet when I'm doing my LP and try to get in a CSF pocket and not necessarily puncture that filar cyst. All right, this is a abnormal finding that you might see. And I should say that, if we have any question before we do our LPs, if we have any question on our point of care ultrasound, we will often order a radiology spine ultrasound if we suspect any abnormality. So this is a fatty filum terminale. On the left side of the screen, we barely see the tip of the conus medullaris. And coming off that, you can often see a normal filum terminale, but this is very, very thick. And here it is in transverse view. Can be a normal variant, can also be associated with it's I'm blanking. Monty, help me. Tethered cord. Sorry, tethered cord. All right. So let me switch slide decks and I'll pass the baton to Monty.
All right, as Jason gets my slides up, I just wanted to kind of transition over how to get an LP program going, but also just like how we initially learned. When I thought about it for my group, Jason's been doing lumbar puncture since the year I started learning how to drive. Um, so really what my group for me at this point, I've kind of become like as I recently found out most content creators have their own like photographers, which oftentimes tends to be their significant others. For my ultrasound group, I'm really just that guy. I do like all the videos and stuff, and people like Lauren Delcor, who's in this picture, Mohammed Al Rayad, who's one of our LP experts, Beth Earhart and Caleb Cave do all the hard work. I just do the pictures. So what we learned early on is we need to practice. We watched Jason's lectures and we're like, well, how do we do this? So here you can see we're practicing. This is one of my children. We're practicing just how to do the procedure. I promise we didn't poke any one of my children as we did this. Next slide, Jason. And again, Jason's piloting these slides for me. And so here you can see we use volunteers and we kind of learn. Here you see a large linear probe and people just learning how to hold the probe and scanning up and down to see the different levels of the spine. Next slide. And then here you can see how flipping the probe changes it. And what I really want to highlight in these pictures is it takes time, right? Like if you look at how the probe is being held behind the user's hands, it takes time to stabilize it. So this really speaks to what Jason was saying. First, learn how to find the fluid pockets in a static manner before you incorporate it into your dynamic scanning. Because that's what's going to help you learn how to stabilize the probe when you do move into the more dynamic approach. Next slide, please. And here you can kind of see that in a split screen. You're highlighting some of the same things here that Jason was highlighting. In that longitudinal view, you see that cauda flipping up and down. And what I really want to point out from some of these slides is our pictures might not look as perfect as the ones that Jason had been showing on his films, but you can get to those same kind of images. And here you can see that flip as the user orients from that transverse to the longitudinal and vice versa. Next slide. So for us, a lot of this was initially practicing it and working out the kinks in either a seated manner or side-lying manner. I know one of the questions that was brought up was the use of devices to position patients. We have moved towards that. My group as at large is trying to figure out how to best incorporate it. But we did take away a lot from other groups who've used it. We've used it in patients up to 5 kilos. Our ER colleagues have as well. The big limiter really turns out to be the really small patients, actually. And I think Jason and I can answer that question in the actual webinar component of this as well, as far as our luck with smaller patients. Next slide, Jason. And this is what you kind of end up seeing, as Jason pointed out, is this needle entering. And I'll talk about how we get this view in the next couple of slides, because our approach is slightly different than Jason's. All right, next slide. So this is how our room setup looks. What we'll do is have a sterile field on one side. The proceduralist is on the left-hand side. This is Lauren Delcourt, one of our nurse practitioners. We have a sterile field set up next to her, and the ultrasound machine is set up just to the right. That way, there's enough room for a nurse or a holder to position the infant. Next slide. And here you can see how that looks closer up. The positioner is right underneath, and here's Lauren kind of feeling out the different spinous processes. I'm sorry, this is a video. It's a little bit glitchy on Jason's end. I'll blame Jason's bandwidth. But you can see how in our approach, we hold our probe just below the midline. We call this a paramedian approach because the probe is off of the middle. This is something that we can talk more about because we're lucky enough to have additional speakers for this. And this is what Lauren's kind of doing here. She's finding the right spot. And then here you can kind of see the needle divot in. And then by moving into that longitudinal to transverse approach, you can kind of verify that needle. And here's probably a better picture of that. You can see that needle is coming in a midline position while the actual probe is just off of midline.
You want me to go back and pause it there?
Yeah, that'd be nice. And so if you see that right there, as you saw from Jason's, their approach is really coming in right at midline, right? The probe is sitting in midline and the needle oftentimes is caught coming in from either the bottom of the field or to your right or to your left, right? It comes from that right to left if the probe marker is pointed towards the patient's head. And in this case, you'll see it coming in towards the middle of your screen because the probe is just off of midline. And this is really where that angle of inclination plays a big role, right? Because you almost have to tilt your probe tail down as the needle is coming in a similar trajectory. The one thing I do want to highlight, and if maybe Jason, you can pull into the very end of this clip, is initially what we were doing was a static approaches. What made us really move towards a more dynamic approach is as we scanned more and more, we were finding that the spinal cord and where the CSF pockets were different than what we were traditionally used to. For example, we'd often find the anterior superior iliac spine and then look around those regions and find that that was actually the portions that the canal was the narrowest, i.e. we had the least amount of fluid. Similarly, as you can see in the end of this picture or the end of this video, if we're able to pull it up, what happened was that someone did it initially without ultrasound. They poked and weren't getting fluid. So then we went back and were able to look again. That's okay. We can try to figure it out in a second here. But what we found was that the cord was actually low. It was a low-lying conus. And we could actually see the needle divoting into right above the conus medullaris. And then when we actually repositioned it, we got CSF out, but it was more along that fluid space where you're really not supposed to be poking. I think in this video, Jason, if you play it and just scroll it, I know it's kind of lagging. This is the following slide. But again, we've been able to leverage different kinds of probes to do this. I know one of the big things that comes up is, well, these probes are super expensive. We have had pretty good luck with some of the cheaper wireless probes and those that'll hook up to mobile devices like iPads and iPhones. And this is one of those probes. Again, we're a brand agnostic group. It's just to kind of show that, hey, the view looks pretty good. And this is using a vascular access mode in one of these probes, where you can actually see both at the same time. You can see that transverse and that longitudinal view. And you can basically follow the needle both in the long axis and the short axis. Could you go back to not this slide, but the previous slide, Jason? Yeah, and so just to keep an eye on this one, because I know we have a couple of other speakers who we'll introduce in a second. But this way you can kind of get a feel for different approaches that are used. The final thing I will say is something that we have moved towards doing, and we're happy to share more of this and different documenting all of this within our EMR so that we can keep track of outcomes. The things that we've incorporated into our Epic notes, which actually Jason's group has listed within the larger framework of Epic, are the use of ultrasound one, the types of needle that are used. What we recently found out through advanced searching is that some needles are easier to see than others. And then finally, we were also able to track the use of the actual devices as we were doing this. So there's a few questions in the Q&A, which I think maybe Jason and I can address real quick because they build off of what was mentioned. Do you recommend using this method if first LP attempt without imaging fails? That is something that at least my group has moved towards. What we were initially using point of care for a lot was almost as a rescue methodology. We would have babies come into the ER who had been poked a few times, and then we would be the second scanners. So we would look and first make sure if there was a hematoma. Is it something that, initially when we saw a hematoma, we would just stop. Like we didn't feel like our skill sets were quite there where we could do some of the fancier things like, hey, let's poke over here or poke like this. As more and more people have learned and become comfortable, we're often able to do rescues pretty effectively. One of our fellows is actually doing active research into this, is what is first attempt success like in the ER and in the NICU as more and more people learn point of care ultrasound usage. And if we do specific training programs for lumbar punctures, so that is kind of becoming our standard. We have a core group of people who feel comfortable scanning and poking. But initially, I think, Jason, you'd agree, I think it works well when you do the static approach first. You basically assess what you see and you kind of get a sense for where to poke, and then you poke. And then over time, you incorporate the skill set that works best for you. And it's how you learn, right? Like we learned that the quinky tip needles, I think those are what's called, are actually the most visible under ultrasound. But our unit stocked three different types of LP needles, right? So things to just kind of be mindful of is what equipment you have, right? That includes things like probe covers. What kind of needles are within the kits? What kind of needles are sitting outside of your kits? The stabilization device has been a relatively new incorporation, and it kind of came from talking to other providers who've used it. Jason, what has been your luck as far as the size that's worked well?
For the small tap? I mean,
Yeah.
it's FDA approved, and it's not necessarily based on the weight of the baby. It's based on the length of the baby. But I'm pretty almost every baby in the average NICU, like no baby's usually too big unless you're a NICU that keeps kids up to like a year. But I think any baby under like 3 months or something is probably going to fit. The bigger issue is the babies who are too small. Might be too small for that device. I know they are coming out with, I think, another version that's made for like preemies, but I don't think it's quite available yet.
Yeah, it's the distance between.
Oh, you dropped out for a second there.
It's the distance between where the head sits and the spinal stabilization portion sits, like where that window is. That becomes the rate limiter oftentimes. It's
Yeah.
almost like you need it to be on a bevel.
But as I said, like, and when I wouldn't worry too much about that small tap device. Like, you can do exactly the same thing with just a rolled up towel and putting them, having them sit and putting the towel on their lap and then putting their kind of their
Could
arms
you
over.
could you pull up that picture? I really like that picture. It's like one of those things where I always want to see it, and I've actually copied it.
You
Hopefully
mean
that's okay.
the
With the
towel
towel.
one?
Yeah.
Yeah. But just while I'm doing that, just the assessing the fluid ahead of time and doing an ultrasound ahead of time, even if you're not going to do dynamic, is really important. So, I mean, somebody asked about the amount of fluid. We've had many cases um, where you're about to do an LP, you do your spine ultrasound, and you see almost no fluid. And, I always thought when people said they got, a quote unquote dry tap, I was always like, oh, come on, you just like missed. You didn't get a dry tap. Everybody has CSF. And now that I've done ultrasounds, I don't know how it's biologically possible, but there are definitely babies who don't have a ton of CSF. And so, if you sit the baby up and you still don't see a sufficient amount of CSF, there's no reason to stick the baby, right? You're just gonna cause them pain with no benefit. So, I might
Yeah.
give them some extra fluid and wait a few hours or wait till the next morning.
And
Um,
honestly, like for me with LPs, initially it used to be kind of the joy of like doing the procedure, and now I'm actually happier for the times that I haven't poked because I ultrasounded, right? Like because I know something is there, I didn't do something.
Okay, thank you both so much. And I just want to make sure that we have time for the whole Q&A panel. This was such a wonderful talk. And so we'll move on to our panel discussion. And as people have already been doing, please continue to put questions into the Q&A and I will relay them to our panelists. And so joining Dr. Sharma and Dr. Stoller, we have the privilege to have Drs. Webb and Drs. Varium today. Dr. Leah Webb is a pediatric anesthesiologist at Children's Hospital Colorado and an assistant professor in the Division of Pediatric Anesthesiology at the University of Colorado School of Medicine. Her clinical interests include acute and regional pain medicine, and she routinely incorporates ultrasound into her daily perioperative and regional anesthesia practice. Dr. Darshan Variam is an attending physician in interventional radiology at Ann and Robert Lurie Children's Hospital of Chicago and an assistant professor of radiology at Northwestern University School of Medicine. His interests focus on vascular access, vascular anomalies, transplant-related interventions, and musculoskeletal lesions, and he utilizes ultrasound in his daily practice, including procedures such as lumbar punctures. So I'd like to start the Q&A session by asking first, Drs. Varium and Dr. Webb, if you wanted to comment on how your approaches to LPs and spinal ultrasounds differ in your fields.
Um, we are primarily using our techniques for spinal anesthesia and more often epidural anesthesia, which is obviously really different from what you guys are doing. But I don't think that I have a ton to add as far as like needle alignment, except that, you know, I think one view that we have that was like sort of covered by what you guys are doing, and I think calling kind of a paramedian approach, is this like horse head sign, or like a parasagittal oblique view where you can do an in-plane technique versus the out of plane and transverse view. But it's just, I think it's just different terminology for essentially, the same thing.
Yeah, thank you so much for inviting me. And it was a great presentation that really covered a lot of the things that we look at also. Often we're being asked to do this when the procedure has failed somewhere else, but I really I I believe that it probably doesn't fail that often. It's probably just dry, and I think that getting that look beforehand is super helpful. But and then we just get, the benefit of getting an overnight bolus of fluid and then coming to us as if we're doing something magical. But we use essentially if you talk to 10 different interventional radiologists, they'll probably have 10 slightly different approaches to how they do this. I use a longitudinal view a lot, which is just right on the midline, right in between the spinous processes, because in the kids, without so much ossification, you can see, pretty well. But sometimes I do transverse too. So we're often doing it with we don't use the static method essentially, just as a function of our training. But so we're always doing it, and I would say that as if you can see the needle and you can see the target, then you're in good shape.
Awesome. Thank you both. Dr. Stoller and Dr. Sharma briefly touched on assessing the amount of CSF affecting whether or not to proceed with an LP. In your opinions, is there a minimum amount of fluid measured in centimeters that's needed to predict more success?
No, I think it's a more of a qualitative approach. I mean, um, yeah, I mean, I, there's no measurement I do. I don't know. Darshan, do you ever measure?
Not really, no, we don't. Sometimes if the interval between when the initial attempt that was unsuccessful and our request is small, we might ask for an ultrasound or ultrasound before we bring the patient down or something like that. But no, there's really no minimum. There are, anecdotally, it's very uh, dynamic. So if the baby's crying a lot, I've noticed that they seem to have the CSF will disappear. So having them calm using your sweeties can be very helpful. The Some of our nurses like the fontanelle massage, so they'll do that, and that can make a difference. So um, even when there isn't much, we're usually being asked because it's the last sort of attempt, and so we will kind of try anything to try to get fluid, so there really isn't a minimum for us.
Do either of you notice a change when people do fontanelle massages?
They seem happy, so the nurses, I mean, the babies too. So no, I don't know if I see much of a difference, but I think calming the baby
Yeah.
probably does make a difference.
Yeah.
Yeah.
Yeah, I agree. I mean, it seems a lot of what we're answering there is like a yes or no, like yes CSF, no CSF. What we noticed from our radiologist, our interventional radiologist, was that person was just asking us to scan and look beforehand before coming up. They're like, wait a minute, he's just making sure that there's more fluid compared to now because he's looking at our older films. So one of the metrics we now follow as a marker of QI success is when did we last use interventional radiology? Sorry, Darshan, you probably don't want to hear that, but
No,
we've
no,
really
no,
cut
that's
down on
great.
interventional radiology tasks by just being patient and waiting for the baby to recover, be calm, allowing CSF to refill. But I agree, it's just so hard to assess volume. Like there's no 1 cm equals X amount of cc's.
Yeah, that makes a lot of sense. Thank you. For the static technique, since skin is mobile, have you had any issues from the marks of do not go above or below moving and causing any complications?
I mean, I wrote an answer to that, but so I think one critical point is that you have to keep the patient in the exact same position when you do your ultrasound compared to when you do your LP. Like you can't do your marks and then walk away and have lunch and come back and do your LP later. Um, I mean, that's one critical point. And then also, I don't exclusively use the marks. I also feel for the spinous process, um, and confirm in my own mind that the marks make sense based on my physical exam also. So hopefully that answers your question, and please, other panelists, chime in if you do something different.
I think what Darshan had mentioned, we moved away from kind of like I haven't done them statically just because it was taking so long to mark everything up. It's like, well, that's the same amount of time as just putting on a sterile probe, looking and poking. I think the one thing I did want to bring up, and someone might have asked this in the chat box, is a two-person technique. I think doing stuff with a friend is always nice, but in ultrasound, it's one of the more challenging things because it's the coordination of your motor skills with your visual skills. It seems like great. Oh, look, someone's holding the probe and stabilizing it while I poke. But actually tracking how my group has been doing this, we've had more success finding the needle when it's the same poker and the same holder. It's like playing a video game. Your brain puts together, hey, I slightly tilted my needle tip down, so I need to slightly bring the tail of my ultrasound probe down as well, so those two things meet, right? Which you can't like I don't know. Jason and I have done these talks enough together. Maybe we do like telecommunicate, but I have yet to be able to do this with anyone where I can achieve both. And that goes for, I think, for many other procedures, whether it's like a chest tube or even like an IV, it just becomes hard to coordinate.
Leah, do you ever do these as a two-person like procedure?
It depends on the circumstance, but I really agree with what Monty is saying. Like, yes, we have ever done them with two people. I think especially in the like acute learning phase, sometimes it's a little more helpful there, while especially to have a second set of eyes. But I totally agree that, once you become comfortable with that hand-eye coordination, it's just really hard to sync up the needle and the probe orientation unless you're doing it yourself.
Darshan and Leah, how big of a patient? Because like as Jason mentioned, we're used to smaller kids, but we're getting more and more requests from like our ER colleagues to kind of learn these techniques. What is the biggest size like where this works?
I don't think there's really a size limit as long as you have a probe that can penetrate deeply enough. I mean, this technology is being used, on OB for obese parturients and all sorts of other like large patients that, have difficult anatomy. So yeah, I think the limitation is how how deep your probe can penetrate. It's
Yeah,
obviously not as easy with the calcified, osseous structures to see through the way you can in the little babies, but you can still see the structures.
yeah, that's the last point is just definitely as they get older and the structures are more ossified, you're not going to see the canal that clearly. But I think the oldest patient that I did at a pediatric hospital was like 25, and he was cachectic. It was a oncology patient, but at minimum, you can find the plane of the interspinous, space so that you can avoid the spinous processes. Uh, so I think it can be
I
beneficial.
mean, like 25 years or 25 kilos?
25 years. Yeah, I know. I mean, honestly, that patient specifically, you could see the spinous processes. So it was just, it was kind of a proof of concept thing because they had been unable to on the floor. So we brought them down but uh, you could still see like interspinous space and you can see a small, tiny window sometimes of the spinal cord
But for those
or canal.
But for those people who are maybe neonatologists at least who or in a quaternary care NICU, and you may hold on to patients until they're 1 year old, um, you're not going to see those beautiful images that Monty and I showed once you get over maybe like 4 or 5 months old. Like then you're going to have to, you're just going to
Yeah.
have to be accepting of much worse views and maybe some alternate views other than the standard transverse and longitudinal view.
Yeah, and that's, I know the clips were a little glitchy on those videos, but the two kids in there, they both those were my kids at different ages, but they were both about 5 months and 6 months. And so that's why when we're scanning, you're not getting that beautiful, beautiful view that we have for some of the term and preterm. Like we really are lucky in that we can scan this way in babies. It does make our lives easier.
Great. So the next question is, what tools are each of you using for providing education to learners on this? Are you using commercial phantoms, homemade phantoms, or are you doing mostly at the bedside education?
Jason.
That's you, Monty.
All right. So that's a great question. We as a group, we are definitely in a still continued learning phase. Even as we do this, I'm taking notes with other people tell me. Um, and one of our fellows, Mohammed Al Rayad, is actually working on what is the best form of education for adult learners, whether that's in the form of lectures, whether it's in the form of webinars, or whether it's the usage of phantoms or one-on-one teaching, right? So hopefully by the time he's done with fellowship, we have more information. Um, Really, I think initially to learn, we first just tried to educate ourselves on how do you hold a probe, what's working well, how can we make the nurses comfortable, right? Like that was the big thing. And that required having volunteers, right? And I'm not saying go have a kid just to like practice how to do lumbar punctures, but you know, we worked with families to say, yes, are you okay? Your baby's doing well. Can we practice? That turned out to be more educational for my group than like any degree of the phantoms were. And we have looked into commercial phantoms. There are some. The problem is that the ultrasound compatible ones are adult size. So sure, you can translate some of those skills. And then the baby one is not ultrasound compatible that we use. But again, it's more for like that hand practice. You might not be able to see it, but you're just practicing that skill. So when you go into your first procedure, you're doing that. I do think doing these simulation type things with the nursing staff is so critical because the buy-in is so much better because then you know how the room is supposed to be set up. Like, if you look at our screen, it's like over here. That took work with the nurses to figure out that, hey, how can we place the screen where we can see it, but it's not in your way, that you can still assess your patient? Because what you probably don't want is to have the screen like behind you, right? That's gonna like break your neck, and then you might need like an LP or something. But
I just put a huge list of phantoms in the chat. We do not use any of those. I have practiced with one at an ultrasound course once, and I was not that impressed with it. So what we do a lot is we just do regular spine ultrasounds, as part of our clinical practice, and we grab trainees to watch and practice. And
you practice on your trainees.
yeah, they don't mind.
It's POCUS.
Um,
That's why they have 6 fellows a year. Some of them go down.
But
I'll just add, like, I don't have a great neonatal model, and it's a big thing for me that I'm hoping to maybe work on. But I've published a little bit on like a ballistics gel phantom that we made for teaching our trainees, and it is an adult spine model embedded in the ballistics gel. And I think along the lines, I think mostly of Monty, what you were saying, like it has very good bony landmarks, which again is not so necessarily relevant in neonatology, but you can see the cartilaginous structures, and I think it's helpful for kind of practicing the probe orientation and then again the like hand-eye coordination of how you line things up without that was one of my biggest frustrations of learning regional anesthesia and all these things is there aren't great models out there. And so you're learning hand-eye coordination if you're not a huge, video gamer like my husband who just does it innately. You're learning on patients, and so just the ability to like practice that and see.
I think you paused there. You're muted, Leah.
I sure did. Anyway, I think that, it's like a relatively cheap Phantom and just the ability to do the work on the hand-eye coordination stuff and get like a basic view of what it looks like. It's somewhat of a relevant surrogate, but nothing is as good as scanning babies.
Also like a translatable skill in my mind, right? Like if you become good at like bladder taps, then I would say that LPs are harder than bladder taps, but they're easier than IVs, right? It's like that tiered structure where the education you get from one thing and learning you can start to apply to others. I don't know. For you guys, and I don't know, Jason, where would you rank this as a difficulty thing? I thought this was easier than IVs. Leah's probably like no, because
I think it all depends on your holder. I think that's a big thing, especially like with the squirmy baby. If you have a good holder, then yeah, I think, it's a slightly bigger window than the IV, but it's I think yeah, it's all in the holder.
I mean, static is simple. I feel like a take-home message for all the listeners is like there's no downside of doing a static LP. You're just doing a lumbar a spine ultrasound, right? It's not really a procedure at all. Um, but I think partly what makes it, I would say, more difficult than vascular access is just the volume, right? Even though like we do a fair amount in the NICU, each individual person is not doing that many LPs. And so if you only do it once every 2 months, it's hard to get really good at it. Darshan probably does like 10 a day, so he can get good at it. But for us, I don't know, speaking personally, like, it's much less common, whereas vascular access, like,
yeah.
they're called all the time.
I think that is a good thing to track, though, right? Someone had brought up the Epic templates. Most of these your Epic technicians can find. Like Jason's template and my template are both discoverable for the like within the Epic community libraries. Um, and the nice thing is they're built in a way where you can have data pulls from your analysts to say, hey, this is how many were done across the institution. This is where the device was used to stabilize. This is the kind of needle and whether ultrasound was used or not. Like that, those kind of metrics are nice to follow because then you know what's working, what's not. I think someone had asked a question about billing for this procedure. The notes are built in that way, but it's hard to get reimbursement in our critically ill patients just with bundled care, but that's really state and payer dependent. I don't know if you guys bill for LPs, but it's something that while we can, there's never really a patient that fits that criteria for us, Jason, because they tend to also be critically ill simultaneously, unfortunately.
Yeah, I think NLP is part of our bundled care. I mean, I'm certain that IR bills for it, but
Yeah.
I'm sure we do. I don't know. I'm not good at that stuff.
yeah,
Well,
so I
this
know
has been such a wonderful and engaging discussion, but unfortunately we are out of time. Sorry, I didn't mean to cut someone off if they had last. Dr. Soliot, anything else you wanted to add? Okay. Thank you to all of our speakers and panelists for sharing your expertise and your time with us. And thank you to everyone who joined today to listen in. Our next educational event is our monthly office hours on April 3rd at 4 p.m. Eastern Time, where you can submit your own POCUS images for feedback and review. Keep an eye out for an email from the Neo-POCUS Collab with more information on registration and image submission for that event. We will not be having an April webinar due to the overlap with the PAS conference. However, if you are attending the conference, please come join the Collab's meet and greet on Saturday, April 25th at 12:30 p.m. Please join us for our May webinar, which is POCUS and Artificial Intelligence, What Comes Next, with our guest speaker, Dr. Kumar. Registration will soon be available through our website and will also be sent out through our listserv. To receive those emails, please sign up on the website. In the chat, you will see a link to the NeoPOCUS Collab website, where you can also find recordings of all of the webinars. Thank you so much, and we'll see you in May.